Calcaneal fractures.
Introduction. Calcaneal fractures are the most common fractures of the tarsal bones, representing up to 65% of all cases. They typically occur in young, active males between the ages of 20 and 40, most often following a fall from height or a motor vehicle accident. Importantly, up to half of patients will also have associated injuries, such as spinal fractures or injuries to the contralateral foot.
Anatomy. The calcaneus is a complex bone that forms the heel. The tuberosity serves as the attachment for the Achilles tendon. The anterior process articulates with the cuboid bone. The sustentaculum tali supports the talus and serves as a key landmark during surgery. Anatomy. Tarsal canal and tarsal sinus. Funnel-shaped areas situated anterior to the posterior talocalcaneal joint and posterior to the talocalcaneonavicular joint. The larger tarsal sinus opens laterally and tarsal canal extends medially, posterior to the sustentaculum tali. Anatomy. Lateral calcaneal artery, LCA. Terminal branch of peroneal artery. Dominant blood supply to the corner of the lateral extensile approach. Lateral malleolar artery, LMA. Branch of anterior tibial artery, lateral tarsal artery, LTA. Branch of dorsalis pedis. Anatomy. Lateral calcaneal artery, LCA. Lateral malleolar artery, LMA. Lateral tarsal artery, LTA. Sural nerve and peroneal tendons at risk with lateral dissection. Anatomy. Lateral calcaneal artery, LCA. Lateral malleolar artery, LMA. Lateral tarsal artery, LTA. Sural nerve and peroneal tendons at risk with lateral dissection. Anatomy. Lateral calcaneal artery, LCA. Lateral malleolar artery, LMA. Lateral tarsal artery, LTA. Sural nerve and peroneal tendons at risk with lateral dissection. Initial assessment. Physical. Note condition of skin. Fracture blisters, threatened skin, open wounds, detailed neurovascular exam. Associated injuries. Serial exams in the first hours after presentation to monitor for compartment syndrome. Initial assessment. Physical. Compartment syndrome following high-energy calcaneal FX estimated in 10 to 50%. Clinical presentation. Pain out of proportion, tense swelling, pain with passive stretch, sensory changes on plantar foot, and presence of blisters. Surgical decompression often complicated by wound dehiscence, infection, nerve injury, dry itchy skin, and chronic pain. Early cryotherapy and elevation may allow soft tissue swelling to stabilize and alleviate pain in the acute period. Initial management. Apply bulky splint in neutral dorsiflexion or slight equinus. Period of soft tissue rest to allow for swelling to subside. Await return of skin wrinkling and resolution of blisters. If skin at risk, e.g. tongue type or tuberosity avulsion fracture, urgent surgery is indicated. Resolution of blisters and swelling prior to surgery. Note skin wrinkles. Radiographic evaluation. Initial imaging includes AP, lateral, and oblique foot radiographs, plus an ankle mortise view. The Harris axial view is essential. CT scanning is the gold standard for fracture characterization. Consider plain radiographs of the lumbar spine and contralateral foot, if warranted, to rule out associated injuries. Intraoperative image of how Harris view is obtained. The lateral radiograph allows assessment of the posterior facet, middle facet, calcaneocuboid joint, and overall calcaneal height and length. It also helps distinguish tongue type from joint depression fractures. PF posterior facet, MF middle facet, CC calcaneocuboid. Bowler's angle. Bowler's angle is measured between the anterior process, posterior facet, and tuberosity. Normal values are 25 to 40 degrees. A decreased angle suggests joint depression. AP X-ray. The AP view shows extension of the fracture into the calcaneocuboid joint and helps assess lateral wall blowout. Harris heel view. The axial view evaluates calcaneal width, varus or valgus of the tuberosity, sustentacular rotation, and lateral wall blowout. Broden's view. Broden's views are oblique intraoperative images used to evaluate posterior facet reduction. Sequential angulation shows the facet from anterior to posterior. CT scan. CT scans are obtained with 3 mm cuts perpendicular to the posterior facet. Coronal images assess the posterior facet and sustentaculum. Axial images show tuberosity displacement, and sagittal images demonstrate facet depression. Pathoanatomy. Intra-articular fractures result from axial load driving the talus into the angle of Dissection. Hindfoot position determines fracture line location, and force direction determines whether the pattern is joint depression or tongue type. Pathoanatomy. Intra-articular fractures result from axial load driving the talus into the angle of Dissection. Hindfoot position determines fracture line location, and force direction determines whether the pattern is joint depression or tongue type. Tuberosity avulsion fractures. These extra-articular fractures occur mainly in elderly patients due to Achilles tendon pull. Posterior skin compromise makes them surgical emergencies. Anterior process fractures. These may occur in isolation or with intra-articular fractures. Most are treated non-operatively unless more than 25% of the calcaneocuboid joint is involved. Treatment considerations. Patient age alone is not a contraindication to surgery. Comorbidities matter more. Smoking, diabetes, and vascular disease increase complications. Injury severity, surgeon experience, and soft tissue condition strongly influence outcomes. External fixation. External fixation can be temporary or definitive, restoring height, length, and alignment while protecting soft tissues. Technique. External fixation. The external fixation technique involves the strategic placement of Schanz pins in the medial distal tibia, the medial calcaneal tuberosity, and traversing from the medial cuneiform into the middle of the lateral cuneiform. Once the pins are positioned, the calcaneal tuberosity is manipulated to achieve reduction. This maneuver aims to restore the tuberosity's height, length, and translational alignment while simultaneously correcting any varus or valgus angulation. Goals of operative treatment. The goals are restoration of articular congruity, calcaneal width, height, and length to optimize gait, shoe wear, and long-term function. Extensile lateral approach. This approach provides excellent visualization but carries a high risk of wound complications. Careful flap handling, systematic reduction, and stable fixation are critical. Technique. Extensile lateral approach. Positioning. For the extensile lateral approach, the patient is placed in the lateral decubitus position on a beanbag, utilizing blankets or a foam ramp to create a stable platform for the operative limb. It is critical to ensure the hip can achieve adequate external rotation to facilitate necessary intraoperative imaging, specifically Broden's and Harris axial views. To accommodate this setup, the C-arm is positioned to enter the field at an angle from the foot of the bed. Technique. Dissection and flap management. The procedure involves raising a full-thickness subperiosteal flap, during which meticulous care is taken to identify and protect the sural nerve. The calcaneovibular ligament and peroneal tendons are elevated integrally with the flap to maintain their vascular supply. To minimize soft tissue compromise, a no-touch retraction technique is employed. Instead of manual retractors, the flap is held open using Kirschner wires placed in the fibula, talar neck, and cuboid. Technique. Fracture reduction principles. While intra-articular calcaneal fractures exhibit significant variability in their fracture patterns, they present with consistent features regarding deformity and fragment position. Typically, the sustentaculum tali remains attached to the talus, serving as a stable, constant fragment. In contrast, the anterior process characteristically translates dorsally. The tuberosity fragment undergoes a predictable multiplanar deformity driven by the pull of the Achilles tendon. It displaces superiorly and laterally, rotates into varus, and shortens into the fracture site. Technique. Step-by-step reduction. The reduction procedure begins by reflecting the lateral wall to expose the underlying fracture pattern. The reduction sequence typically proceeds from anterior to posterior. First, the anterior process is aligned and reduced to the sustentaculum tali. Following this, the tuberosity is manipulated to correct its position, specifically being levered out of varus deformity, and is then reduced to the sustentaculum to complete the restoration of the calcaneal anatomy. Technique. Step-by-step reduction. Sequence. The reduction procedure begins by reflecting the lateral wall to expose the underlying fracture architecture. The reduction sequence typically proceeds in an anterior to posterior direction. First, the anterior process is aligned and reduced to the sustentaculum tali. Subsequently, the tuberosity is manipulated to correct deformity, specifically being levered out of varus, and reduced to the sustentaculum. Finally, the lateral posterior facet joint fragments are reduced to both the sustentaculum and the talar facet above to restore the articular surface. Technique: plating and fixation strategy. Once reduction is achieved, a plate is applied to the lateral aspect of the calcaneus. This implant serves as a washer for the screws, compresses the lateral wall, and acts to resist deforming varus forces. To ensure robust fixation, screws should be targeted toward areas of dense, high-quality bone. These optimal zones include the subchondral bone of the posterior facet, the angle of Gissane, and the calcaneocuboid joint, as well as the sustentaculum tali and the tuberosity near the Achilles tendon insertion. Technique: wound closure. Careful, soft tissue handling is critical during the closure phase to minimize the risk of wound complications. The technique involves placing all periosteal subcutaneous sutures first to ensure accurate alignment of the tissue layers. Subsequently, the flap is reduced to the apex to strictly restore the anatomical position of the soft tissue envelope. Technique: wound closure. Careful, soft tissue handling is critical during the closure phase to minimize the risk of wound complications. The technique involves placing all periosteal subcutaneous sutures first to ensure accurate alignment of the tissue layers. Subsequently, the flap is reduced to the apex to strictly restore the anatomical position of the soft tissue envelope. Technique: wound closure. Careful, soft tissue handling is critical during the closure phase to minimize the risk of wound complications. The technique involves placing all periosteal subcutaneous sutures first to ensure accurate alignment of the tissue layers. Subsequently, the flap is reduced to the apex to strictly restore the anatomical position of the soft tissue envelope. Summary: management principles. Calcaneus fractures are potentially debilitating injuries that require a thorough radiographic assessment to characterize the fracture pattern and associated soft tissue injury. The decision to proceed with operative management must be carefully considered, paying particular attention to patient characteristics, specific injury factors, and surgeon experience. These host and injury factors play a critical role in determining the appropriate surgical approach. Ultimately, the guiding principle in managing these complex injuries is to do no harm, ensuring that the chosen treatment plan optimizes outcomes without introducing avoidable complications. Thanks for watching. Subscribe Orthopedics Trauma in YouTube.